Hi, everyone. Let's go ahead and get started. My name is Sally Safi, and I'm the Director of Graduate Studies in the Department of Population, Family, and Reproductive Health. And I've had the pleasure of advising and or working with many of the students who are presenting today, which has been an honor. And so very excited for this session today. Thanks a lot for joining us. This is the second session of our series of presentations for PFRH master's essays. And so we'll have 5 students present today. And I think that we're just going to go ahead and get right into it. But first, I do want to give a special thanks to all of the essay readers. I think that many of you have joined us today. So thanks for spending the time with students. And just, again, very, very proud of all of the students for doing this work and really excited to hear the summaries. So we're going to go ahead and get started with our first presentation, which is by Aries Nuno, and she went to the University of North Texas and has a bachelor's in public health, and she'll be presenting today about her essay on female genital mutilation or female genital cutting. So Aries, take it away.
Thank you for that introduction, Sally, and thank you all for tuning into my presentation today, which is titled Exploring the Experiences of FGMC-Affected Migrant Women in Western Nations, a scoping review of accessing sexual and reproductive health services. So just starting with a brief definition of FGMC, which stands for female genital mutilation / cutting, sometimes simply referred to as genital cutting, is a cultural practice that involves the partial or total removal of external female genitalia for non-medical purposes. FGMC is officially recognized in 30 countries throughout Africa, the Middle East, and Asia. And you can see on the map highlighted here by the dark purple, it might be a little small to read, but that's because these countries have nationally representative surveys on FGMC. However, evidence indicates that the practice can be found in at least 92 countries around the world. So what I really wanted to focus on was the impact of globalization and migration on individuals from countries where FGMC is prevalent, recognizing that women affected by FGMC have unique health needs that may not be understood or acknowledged by social institutions and systems where FGMC is not a social or cultural norm. So this, coupled with the underreported nature of FGMC, makes it crucial to examine the challenges faced by these women. And just to add, there have been reports of the continued practice of FGMC within diaspora communities through covert measures such as performing FGMC at an early age, medicalized FGMC, or vacation cutting. So overall, contributing to the emergence of FGMC as a public health issue in Western countries. So as it stands, current literature is largely focused on the clinical aspects of FGMC, as this can be a very traumatic experience, resulting in a range of physical and psychological health consequences. Therefore, research has been conducted to understand the enhanced risk that women with FGMC face in relation to sexual reproductive health. Many studies have also been conducted to get a better understanding of the providers' perspectives and their experiences caring for patients with FGMC, and also the level of confidence in which they deliver care. What appeared to be missing, however, were the patient experiences and the voices of women impacted by FGMC. Therefore, the 2 main objectives of this review were to first provide an overview of the existing literature, including information on the host countries, the population groups, and types of sexual reproductive health services analyzed. And second, identify common barriers and facilitators impacting access to sexual reproductive health, and just sort of synthesizing all of this information. Okay, so applying the ARC-C and O'Malley scoping review framework, this is just a brief slide outlining the study selection process. So after removing duplicates, 450 articles were screened, and based on the inclusion criteria that you see here, 18 articles were included in the final review, with 3 articles included through bibliographic searching. Okay, so just jumping right into the results of this review, the first half of the slide provides a visual representation of the population groups and host countries included in the studies. So research has been conducted in Canada, the US, Australia, Spain, Norway, and as you can see, many of the participants originated from various countries in Africa, including Eritrea, Nigeria, Somalia, Sudan, and one study did include participants from Indonesia. So for the areas of sexual reproductive health analyzed, A majority of the articles were focused on maternity and obstetric care, reflecting on patient experiences with gynecological examinations, cesarean deliveries. 3 articles included were more focused on FGMC-related care, which kind of involved care seeking for more general women's health issues that were triggered by FGMC status, so such as urinary tract infections or menstrual pain. And then 1 article included reflected on experiences with seeking reproductive surgery and more specifically clitoral reconstruction. Okay, so 5 themes emerged with respect to barriers and facilitators. The most commonly cited theme was the lack of communication and support, with many women reporting that the care they received was often uninformed. The underlying cause seemed to be related to several communication barriers between women and their providers, such as language differences, discomfort discussing FGMC, and also overarching cultural and gender norms, which limited discussions about sexual reproductive health. Furthermore, women reported that these barriers often prevented them from being able to ask questions, understand care options, and overall participate in the decision-making process. In a similar vein, the very cut and dry approach by providers created an unwelcoming environment, which notably affected postpartum women who would have appreciated more empathy and support during the birthing process and afterwards. And you can see that kind of highlighted here by this quote. Okay, the second theme found were challenges related to fear, trauma, and re-victimization. Ultimately, the fear of judgment was a major concern. Women felt that their FGMC would subject them to scrutiny. Therefore, they often avoided disclosing their FGMC status. Additionally, invasive procedures such as episiotomies or defibrillation for some women were traumatic reminders of their initial experience with FGMC, and therefore they faced certain situations with a level of anxiety or sometimes even panic attacks. And the quote at the top of this slide kind of emphasizes that sentiment. And finally, women reported feeling re-victimized when healthcare providers seemed to blame them for their FGMC or when requests for reinfibulation were refused. Reinfibulation was often sought as a means to be restored to their perceived normal state, and its refusal led to feelings of stigma and discrimination. So this slide highlights how the insecurity and discomfort of women affected by FGMC were related to a healthcare provider's ability to manage their condition. Sometimes offhanded remarks or assuming preferences for care, and overall inexperience with FGMC contributed to negative interactions with a provider. So as a result, women were frequently subjected to iatrogenic outcomes due to mismanaged FGMC. A lack of continuity of care similarly made women feel vulnerable, as this required women to undergo frequent examinations and having to repeatedly explain their medical history, concerns, and preferences to each new provider. Furthermore, the lack of cultural sensitivity and a provider's medical interest in their FGMC added to their discomfort. So this quote at the top here kind of highlights one woman's experience with providers failing to respect their patient right to privacy. The fourth thing,
they're moving forward with the commissioning.
The fourth theme found was related to the overall inaccessibility and delayed care seeking of women with FGMC. Women appear to encounter both structural and sociocultural barriers. So some of the health systems related barriers included insurance restrictions, limited availability of specialists, and a lack of awareness of some specialized services. So for example, psychosexual healthcare. And the quote above here highlights the challenge with insurance coverage women in Canada faced, and sometimes they even reported seeking more affordable options here in the US. Some of the sociocultural factors included family influences and social stigma, impacting the way women interacted with the healthcare system. For example, some women, though they desired to undergo defibrillation, they were worried that people from their community would find out and then spread rumors about them for not ascribing to social norms. In addition, women often resorted to self-management, such as applying home remedies and seeking advice from friends and family before seeking professional care. And the final theme that emerged from the research highlights the influence of one's cultural background and prior experiences on expectations and preferences for healthcare services. So, despite facing negative interactions with healthcare providers in their host countries, many women reported being generally satisfied with the quality of care that they received, often drawing comparisons with available services in their home countries. This, however, also contributed to a sense of distrust towards providers and towards certain practices, such as drawing blood during perinatal visits, which was not always a standard of practice back in their home countries, and also cesarean deliveries, which had negative associations with maternal mortality. What was particularly frustrating for these women, however, was the disregard for their input on how to manage their FGMC, given their own familiarities with their body and also with how providers back home would take care of them. So here I've just summarized 3 considerations for improving interventions. First, enhancing the training and education of healthcare providers on FGMC to deliver better patient-centered care, from allowing greater input from the patients themselves, or even collaborating and consulting with providers from countries where FGMC is prevalent. Furthermore, improving partnerships with community-based organizations, as it was found that women often relied on informal networks for health support and advice. And lastly, engaging policymakers and advocates to address overarching structural barriers, such as the issues with insurance coverage and awareness of available services. And these are just a few of the limitations to the review. However, most notably, the majority of the articles focused on maternity and obstetric care, which is not comprehensive of the full scope of sexual reproductive health services. And also, majority of the women included in the articles self-reported having type 3 FGMC. However, given the exploratory nature of the proposed research questions, the flexibility of a scoping review was found to be most suitable for providing an overview of the current literature and guiding future research on this topic. So hopefully in the future, we look to diversify study populations, include the perspectives from individuals with different types of FGMC, and also engaging other host countries to do research in their care settings, and also potentially consider other forms of data collection, as a formal research process may be restrictive to gaining a better understanding on this topic. And I'm not sure if I've gone over time, so I think if anybody wants to ask me a question about the inspiration for this research, I welcome them to do so. These are my references. And of course, a big thank you to my reader, Dr. Asta Ramaya, Sally Safi, my advisor, and to my friends and family for the love and support during my academic journey. Thank you all very much.
Great job. Thank you so much for presenting. We do have time for a couple of questions, and I would take a student question first. So who would like to ask a question? Feel free to come off mute or type in the chat. All right, I see a question from Shira in the chat, which is, why do you think a majority of the articles focused on maternity and obstetric care?
That's a good question. I think it has to do with a few things, partly because already women were delaying seeking care. And so something as serious as having to finally deliver their baby, then they do seek going to a hospital. And also, I think because of the direct impact that FGMC has on reproductive organs, I think there's just generally more research has been conducted in this area.
Overall, really great job, Aries. I thought it was great. So earlier in your presentation, you'd mentioned vacation cutting as a covert practice, and I was wondering if you could explain a little more about what that is.
Yeah. So vacation cutting is a phenomenon that has been reported where basically like during school holidays or like a winter break or something, families would send their daughters back to their country of origin or to their home country to undergo FGMC. So there hasn't been like any research specifically conducted on this, but there have been like news reports and things like that. And I think I saw.
So Tanisha asked about your inspiration.
Yeah, great. So what initially inspired this research inquiry has been my volunteer work with a nonprofit called SEO. And I just wanted to highlight their Voices to End FGMC project, which utilizes a storytelling approach for survivors to share their experiences living with FGMC. And so, I mean, if you just get a chance to look into some of their stories, you'll see that some people do reflect on their experiences with sexual and reproductive healthcare services. And there are also some stories from individuals who identify as non-binary, and also people from countries where FGMC isn't nationally reported. So Sometimes they're kind of overlooked in the global effort to end the practice. But like the work of this organization and many others just emphasize the need to recognize the complexity and heterogeneity of FGMC practices, but more importantly, the individuals affected by the practice. So yeah, check them out if you get a chance.
Great, thanks so much for sharing that. And again, excellent job overall. Congratulations.
Thank you.
We're going to go to our next presentation now, which is by Janna Rudolf. Janna has a bachelor's from the University of Wisconsin-Madison, where she majored in international studies, and she'll be presenting her essay on family planning clinics in Burkina Faso. So I'll hand it over.
Can everybody see the slides okay?
Yep, looks great.
Awesome. Okay. Thank you for the introduction. Today, I will be presenting on my master's essay, Empathy Training as a Means for Provider Behavior Change in Private Family Clinics in Burkina Faso, a qualitative analysis from providers' perspectives. So starting with a little bit of background about the current state of family planning in Burkina Faso. Burkina Faso still experiences a very high unmet need for family planning at a rate approximately around 23%. From the opposite side of the statistic, only 28.3% of all women, both married and unmarried, currently use some form of family planning. So this equates to about fewer than 1 in 3. And this has caused a high rate of unintended pregnancies at a rate of about 22%. There are many different factors that lead to these outcomes. However, today we're going to focus on systematic barriers that these women face to accessing contraception. Systematic barriers are defined as practices or procedures that affect one's interaction with the healthcare system, resulting in unequal access to or exclusion from health services. Some of the most common systematic barriers experienced by women in Burkina Faso are lack of trust in the healthcare providers and low levels of quality care. This can look like providers treating their patients based on their own biases and prejudices and low motivation to help patients. A common way to address these systematic barriers is to use provider behavior change interventions. Provider behavior refers to the way that providers act in response to people or situations while delivering healthcare services to their patients. So PBC interventions aim to positively change the way providers interact with their patients. For example, reducing the extent to which they treat patients based on their existing biases and approaching patients with a patient-centered lens. So prior to this study, there was a scoping review done on previous PBC interventions in West Africa. The study found that only 17 PBC interventions had been performed and only 2 of them were implemented in Burkina Faso. The study found that most interventions were based on supervision and training, and that the strategy least used was values clarification, which is essentially an education-based intervention focused on teaching and reinforcing the importance of acting and treating patients based on certain values. And the only study that focused on values clarification was in Togo. So now looking at opportunity for intervention. The first step of this study were initial clinic walkthroughs. The purpose of these were to observe interactions and pinpoint areas for intervention and improvement. During the walkthroughs, it was found that patient-provider confidentiality was lacking. Providers had difficulty separating their professional and private lives. Providers had developed negative habits, such as being judgmental of patients and being unwelcoming. Providers exhibited poor attitudes and lacked motivation to provide quality care, and they did not involve the patient in the decision-making process. So all of these findings led to the question, how could we improve family planning counseling while focusing on these findings? The solution was the Empathy Kit. The Empathy Kit is a values clarification strategy that contains solutions for reinforcing and emphasizing the importance of acting with empathy when treating family planning patients. And it consists of 2 parts. The first part is the empathy game. The empathy game is a card game with a series of prompts that the providers play together to generate reflection and discussion about hypothetical client experiences, and is designed to provoke providers to think about how empathy can be used. The second part are empathy training sessions. These are sessions where providers come together in a group setting to learn and talk about empathy and its potential to impact their practice. So these all led to 3 study objectives: explore provider perspectives on the intervention, explore how providers feel their practice has been shaped by the intervention, and assess the potential for scaling up an intervention based on empathy. So now moving into the methods. The Empathy Kit was implemented in 8 clinics in 4 different towns in Burkina Faso, 4 clinics in an urban setting and 4 clinics in a rural setting. The clinic in the urban setting is in Bulumugu, and the rural clinics are in Boromodo and Dafra. Provider interviews were conducted in French by team members in Burkina Faso, and all interviews were recorded. So phase 1 interviews happened 1 month after use. 3 providers at each clinic were interviewed, which resulted in 24 interviews after the first phase. Phase 2 interview happened about 2 months after use. Again, 3 providers were interviewed at each clinic, but they were not the same providers that were interviewed in the previous round of interviews. So after both phase 1 and phase 2 interviews, there were about a total of 48 interviews. Interviews were then transcribed from the audio recordings into Word documents by the interviewers in Burkina Faso. Once they were transcribed, the transcripts were sent to the Baltimore office, where we uploaded them to the Deduce platform for analysis. For analysis, we created a codebook based on interview guides and themes seen in our initial readings of randomly chosen transcripts. All transcripts were read and coded in French to ensure that the intended meaning was kept. Then, through a matrix approach, the transcripts were analyzed for emergent themes and sub-themes that were directly relevant to the study objectives. So now moving on to the results. There were 3 main themes that emerged. The first is feasibility of the empathy kit, which is essentially, did the providers think that the empathy kit was practical? The next was the value of the empathy kit. This highlights the value providers placed on the empathy kit. And the last is the overall impact, how providers felt their practice had been shaped or changed since using the empathy kit. Within those themes, several sub-themes were identified. So looking at the first overarching theme, feasibility of the empathy kit, there were 2 sub-themes identified: content understanding of the empathy kit and visual and tactile feedback. So here are 2 quotes related to the first theme, feasibility of the empathy kit. The first quote is from a female provider with 7 years of experience, and the second quote is from a female provider with 1 year of experience. Both women state the content of the empathy kit is necessary and important for highlighting what providers need to do for their patients. These quotes highlight the first sub-theme, the content of the empathy kit. Regarding the second sub-theme, tactile and visual feedback, several providers suggested ways they felt the intervention could be improved so it's easier adopted by clinics. These suggestions included making font sizes bigger, defining important values, and making it more into a notebook style rather than a deck of cards. Now moving on to the second overarching theme, the value of empathy. This theme had 3 sub-themes. Providers said they valued the empathy kit because it increased quality of care due to changes in behavior towards and relationships with patients, improved relationships between providers, and increased self-esteem, confidence, and courage. This quote from a female provider with 2 years of experience says she values the empathy kit because it increased her self-esteem and gave her confidence and the ability to treat patients even if the situation is unfamiliar. Here are 2 quotes also related to the value of the empathy kit. The first quote is from a female provider who says she values the empathy kit because it has improved her relationship with her patients. The second quote is from a male provider. He says he values the empathy kit because of the way it has improved his relationships with other providers and his clinic. So now moving to the last overarching theme, overall impact. Within this sub-theme, 3 themes were identified: providing definitions of empathy, impact of utilizing empathy, and impact of the empathy kit. Here are 2 quotes that highlight how providers defined empathy after using the empathy kit. The first quote is from a female provider with 5 years of experience. She states that empathy is to put herself in the place of the patient. The second quote is from a female provider with 13 years of experience. She defined empathy as putting herself in the patient's place and as making sure to understand the patient's needs by sympathizing with them. Here's a quote related to the last 2 sub-themes of the overall impact, the impact of empathy and the impact of the empathy kit. This quote is from a female provider with 25 years of experience. Here she states how her practice and behavior has changed since using the empathy kit. So now moving on to the discussion, we're going to talk about strengths and limitations. The strengths of the study. The first is that this is one of the first studies that has ever been performed that focuses on empathy for provider behavior change, and specifically the first that focuses on empathy related to family planning in West Africa. Second, the study was able to collect in-depth feedback on an intervention and from the provider's perspective, allowing for understanding of nuances in adaptability, acceptability, value, and feasibility. Third, data was collected at 2 different points in time, allowing for a more rigorous review of how providers view the prototype. And lastly, this intervention has direct programmatic and public health relevance. In addition to the strengths, the study also had some limitations. The first is that we cannot claim or determine quantitative impact on changes in the clinics. Second, the clinics were located in the western region of Burkina Faso, limiting our knowledge on what implementation of a similar intervention might look like in places where social norms and culture is different. Third, the intervention was only implemented in private clinics. Although private clinics tend to be more utilized in this region of the world, we did not get a full representative sample of providers from both private and public clinics. And lastly, the sample of participants was rather small and not diverse. There were far more female providers than male providers. Now moving into public health implications. So empathy training can improve relationships between providers and patients, between providers and providers, and improve the relationship people have with family planning and the healthcare system. Second, empathy can minimize provider biases by limiting the extent to which biases influence the way providers treat their patients. Third, empathy training can encourage a culture of caring and compassion, not only towards patients in the clinic, but towards people in the community outside of the clinic. Fourth, empathy training can lead to a patient-centered care by changing the way providers treat patients. They put themselves in the place of their patients and make patient satisfaction the primary goal of each appointment. Fifth, empathy training can lead to greater equity in healthcare. Empathy can help break systematic norms that perpetuate limited access to certain groups of people by allowing all patients to receive equal treatment regardless of biases that exist in society. And lastly, empathy training can lead to better health outcomes. When patients feel their providers truly care about them, they are more likely to listen and take their advice. Similarly, when providers act with intention towards their patients, they are less likely to make medical errors, leading to better health outcomes. This is extremely important in Burkina Faso as maternal and child health outcomes continue to suffer. And then lastly, my acknowledgements. I just want to thank my readers and my colleagues at CCP, and of course, my family and friends for encouragement and support. Thank you.
Hey, great work. Thanks very much. We have time for maybe 2 questions. Is there a student question first? Pooja?
Hi, Jenna. Great presentation. I just wanted to ask, why was the intervention only implemented in private clinics?
Yeah, so we only implemented them in private clinics because of the political nature in Burkina Faso. Around the time that we implemented, I believe there were 2 coups that destabilized the government and public services. And also the funder of this project, USAID, decided that the projects should only be implemented in legitimate clinics. So we went to private clinics.
So next up, we have Kayla Hurt. Kayla went to the University of North Carolina at Chapel Hill, where she got a bachelor's in psychology. And she will be presenting today on promoting clinical research participation among Black pregnant and postpartum birthing people.
I'm presenting today on an intervention that I developed as a part of my thesis, and it's titled The Bridge, and it's aimed at promoting clinical research participation among Black pregnant and postpartum people. And so I do want to make the disclaimer before I begin that I understand, recognize, and respect the fluidity of gender and its existence as a social construct in our society. And I acknowledge that there are individuals that identify as women who cannot give birth, and that there are people that give birth who do not identify as women. And so throughout my presentation, there are gender terms related to maternal health. However, I will utilize the gender neutral terms to refer to birthing people and individuals as to not limit its definition to just cisgendered women. And so, there we go. And so there we are. So just for some background, so maternal deaths are defined as any death while pregnant or within 42 days of the end of pregnancy from any cause related to or aggravated by pregnancy or its management. And maternal mortality is linked to various complications during pregnancy, many of which are treatable. The World Health Organization declared that in the year 2020, preventable causes related to pregnancy and childbirth are responsible for almost 800 maternal deaths per day. So that equates to about 1 maternal death every 2 minutes. And Black birthing individuals are 3 times more likely to die from a pregnancy-related cause compared to their counterparts. And so maternal health is intrinsically linked to economic and social stability. The Black Mamas Matter Alliance has reported that Black women are more likely to quit, be fired, or return from work before they are healthy after giving birth due to inadequate leave policies here in our country. So it is important for us to recognize the multiple intersecting factors that contribute to the racial disparities that and the lack of health equity that's observed in the burden of maternal deaths in the United States. In addition to that, some of the negative maternal outcomes for Black birthing people can result in increased risk of preterm birth, developmental delays in infants, as well as low birth weight for infants as well. So maternal mortality disparities are not fully explained by the differences in access to healthcare or pre-existing health conditions. And so they are believed to be related to systemic racism and bias in healthcare delivery. The racism embedded in healthcare practices can result in a lack of racial and ethnic harmony between patients and providers, inconsistency of care, and also a lack of resources for systematically excluded and disinvested in groups. And so one way to better understand maternal mortality and morbidity is through conducting maternal research, maternal and postpartum research. However, Black people are often underrepresented in clinical trials, which can limit the generalizability of research findings and further exacerbate the existing health disparities that we see. And so in developing the bridge model, I reviewed lots of literature and lots of studies that examine the unique perspective of Black birthing people and the reasonings for why they are not participating into clinical research. And so these barriers can kind of be grouped into 3 broad categories. The first being a lack of trust among the medical and research community. So thinking about historical studies like the Tuskegee syphilis study, and even the development of the first immortal cell line here at Hopkins with the harvesting of Henrietta Lacks cells back in the 50s. And so also thinking about high cost of participation. So things like time dedication, fear of unintended outcomes, and also the third being being unable to participate due to competing life demands. So understanding that participants are parents, and they're at a very vulnerable time in their lives, and they may have other children, other priorities that may get in the way of their participation to being into research. On the other hand, there are some facilitators that were found in research, going back to that medical distrust piece. Strengthening patient-provider relationships has been found to be a positive facilitator of recruitment and retention, as well as the inclusion of families and communities in dialogue surrounding research. And so the question is, how do we as researchers overcome these barriers to recruitment and retention to not only increase research participation, but also advance positive maternal health outcomes and well-being? And so that's where the bridge comes in. And so I developed the intervention based on 3 core concepts: culture, care, and communication. And so the creation of a culture, like a study culture that's both inclusive and respectful of participants' backgrounds and their lived experiences, and just cultivating an environment that values diversity and promotes cultural understanding is necessary to create a more effective and inclusive research process. Onto the care piece, providing high quality healthcare. It's more important than just simply following study protocols. So demonstrating a genuine care and concern for the well-being of your patients and creating that a sense of compassion and empathy, and letting that be felt between researchers and your participants. And lastly, with effective communication, it's just essential to build trust and rapport between research staff and participants. And so for the sake of time, I won't read all these out to you, but I'll let you read through some of the components of the bridge model. And so I've broken it up into 2 main parts, the first being targeted recruitment strategies. And so as previously mentioned, care, culture, and communication are the guiding principles of my model. And so from a cultural perspective, one of the things I want to highlight on this slide is having diverse study staff, including individuals from similar racial demographics and backgrounds as your targets your study's target population is highly beneficial when you're seeking perspectives on things related to cultural acceptability and appropriateness. And it's also important to note that there is great heterogeneity in the lived experiences of minority people. However, this approach just helps to provide a more nuanced and inclusive understanding of cultural norms that may not be available to outside groups. Similarly, with communication, presenting the study in a way that shows the importance of the focus on the target population and how your study is going to help mitigate the health disparities and improve the outcome of that population. So having that sense of transparency and communication to help also build that sense of trust between participants and researchers. The second part of my model is patient-centered trainings. And again, for the sake of time, I won't go through all of these, but things like demonstrating care and concern for your participants' lives, having flexibility within protocols, which is difficult sometimes in research because you don't want to affect any of your internal validity for your study, but having flexibility that allows your participants to still engage with you, but respecting their lived experiences also. And another really important thing is not becoming so focused on achieving those recruitment targets or completing your study protocols that the human interaction piece of research is neglected. And something very simple that stood out to me that's also in the literature is just being respectful, friendly, and reliable as researchers also helps to build that, that level of trust between researchers and participants. And so the parent study that the intervention was designed with in mind is a study that I've had the pleasure of working on over the last few months, the Healthy for Two, Healthy for You study here at Hopkins. It is a randomized control trial that we are testing a pregnancy health coaching program that's being embedded into prenatal care, and it's being compared to usual prenatal care. And so the Healthy for Two study delivers an evidence-based pregnancy postpartum health coaching intervention that utilizes remotely delivered health coaching, a web-based platform where our participants complete learning activities and also engage in behavioral tracking. And so the goal is to produce, or the Healthy for Two study is to produce and design an effective and scalable behavioral strategy that helps reduce excessive gestational weight gain, prevent future obesity and diabetes, while ensuring high quality care delivery to optimize care for pregnant people at highest risk of developing complications. And so my goal for the bridge is to, over the next few months, since I am having the pleasure of staying on with the study, is working with our staff and with our head researchers on how we can implement some of these things into the program so that we can improve our recruitment targets for our African American participants, as well as just increasing engagement from our current participants over time. And so I unfortunately wasn't able, for the sake of time, to not include the data analysis of the recruitment flow that I've done, but some of the implications for Healthy for Two and also future research for the bridge are participants, especially in our study. One of the facilitators mentioned earlier are that participants that have access to healthcare resources that aren't otherwise available to them are a great facilitator for participation and recruitment. With our personalized health coaching approach, it also helps to build that foundation for a stronger patient-provider relationship. And another facilitator that was found in the literature is having low risk of invasiveness and convenient study protocols also help facilitate participation and recruitment of minority participants, and also studies that allow people to help themselves and promote their own wellness. So with us being with a weight loss study, it's one of those things that people can do to improve themselves. And so that's also been found to be a great facilitator of participation also. Lastly, as I said, I had to omit the recruitment flow diagram that I made, but one of the big implications from doing that was we were able to identify clinics that we recruit from that have lower levels of referrals, and also participants that are being enrolled, and so that we can tailor some of our recruitment strategies to focus on these clinics so that we can increase or have a better, more equitable representation within our study. And so that, I think I'm out of time, but So I also want to acknowledge my reader, Dr. Wendy Bennett, who can't be here today. She's at a conference, and the rest of the Healthy for Two staff that's here, as well as my family who's here and all my friends that have supported me over the last 2 years. So thank you.
Great job, Kayla. Thanks so much. That was really interesting. And we have time for a couple of questions.
Great job, Kayla. I think my question is just overall, like, how did you decide on your topic and what led you to want to learn more about minority research participation?
Yeah, so like I said, I've been working on Healthy for Two now. I started with them for my field placement, and it's been my first experience working in research. But even before coming into the research space and being at Hopkins, I've learned a lot about kind of the history between Hopkins and the Baltimore community, and it was something that before coming up here I wasn't well versed on. And so in learning about it kind of through our classes and different like panels and stuff that I've attended, it's kind of sparked this idea of like, well, what is it like for me being a Black researcher in a predominantly Black city, but at an institution that has issues of trust? And so it was something that I was interested in seeing, not only how it would affect or how it would impact myself, but just how me as someone going into research would be able to help in the future with that relationship that we all know now, that tainted relationship between Hopkins and Baltimore.
Awesome. I can see you're very passionate about this topic, so great job.
Thank you.
Natalie?
Yeah, great job, Kayla. It was really interesting to hear about all this. A quick question. So what was like, I guess, the most shocking reason that Black women noted in the literature as to like why they were hesitant to participate in research?
Yeah, so I didn't include it on the slide, but the thing that was most shocking to me, well, it wasn't like super shocking, but at first it was, but then when you think about it, it wasn't, was that Black women actually noted that they're more comfortable joining studies where they see white people in them or have diverse ethnic and racial participation pools for the fear of, back to that fear of unintended outcomes. They see that if there's a diverse racial pool, that they're less likely to be harmed by participants, because if they harm Black people, they have to harm everyone in the study. And so I thought that was super interesting that that's something that was noted, or that even like came up, and not something that I would have thought about originally, but after like reading about it, I was like, well, okay, like when you think about all the level or the history of distrust in research, it makes sense, unfortunately. But that was definitely one of the things that was most shocking to me.
All right. Well, thanks again, Kayla. This, as I said, really interesting. I think we could talk about this for a long time, but thanks a lot for sharing. And we'll move on to the next presentation, which is by Natalie Zapoteco, who has a bachelor's from UC Berkeley, where she majored in social welfare. And she'll be presenting on a case study on adolescent pregnancy prevention in Nicaragua.
Great. Thank you, Sally, for the introduction. So hi, everyone. Yeah, today we're presenting on Where There Are No Data, a case study on adolescent pregnancy prevention in Nicaragua. So to give some context, as part of my MSPH practicum, I worked with Amos Health and Hope, a local nonprofit in Nicaragua. While they primarily focused on service delivery, in 2022, they decided to create defined health programs to meet their mission. As part of their team, I helped to create their new sexual reproductive health program. Internal and local data were minimal, so the team turned to national data, and it quickly became evident at that point that our primary challenge was the lack of local data to inform the program design. And on the right-hand side is just a little depiction of like where Amos, oh, one sec, sorry. All right, now moving on to give some background. Worldwide, the highest level of unmet need for modern contraception is among adolescents. In low and middle income countries, an estimated 21 million girls aged 15 and 19 years old become pregnant each year. And of those pregnancies, nearly half are unintended. An estimated 5.7 million of those pregnancies end in abortion, many in unsafe conditions. And although adolescent pregnancy rates have been trending down globally, Nicaragua has the highest rate of adolescent births among Latin America and the Caribbean countries. And so this is now a picture on the right hand that depicts the program reach of Amos. Great. So now specifically talking about adolescent pregnancy in Nicaragua. The rates of adolescent births in Nicaragua are among the highest in the world, with 28% of women between the ages of 20 and 24 reporting they had a child before turning 18. In 2015, 1 in 5 babies in Nicaragua were born to women aged 15 and 19. Consequently, girls between the ages of 15 and 19 in Nicaragua have 2 times the likelihood of dying due to complications during pregnancy than those between 20 and 24 years old. So what did we do? Well, we used the data that was available to us as best we could. The most recent information regarding adolescent pregnancies in Nicaragua primarily relies on data published in 2012 and is based on projections from the census collected in 2005. This data was published in the National Preliminary Report of the Nicaraguan Demographic Health Survey, also known as NDESA. The Nicaraguan government has since annually published a yearly statistics, which uses the 2005 census to project population numbers and general data on the number of births per region. However, it does not provide details about age, previous births, or other information that could be useful in designing a program to address adolescent pregnancy and birth rates. Since 2012, no new national, social, and developmental data have been published by the government. So without understanding the magnitude of early pregnancy, childbearing, abortion, and adolescent contraceptive use, it is challenging to make a measured change through a program. AMOS currently collects some routine data regarding contraceptive delivery, so we utilize that to inform program development. We also constructed a quantitative survey to better understand method use. This was modeled after published surveys conducted among adolescents in other contexts. The plan was to conduct the survey among adolescents in the rural region of Matagalpa, a region that AMOS was already in the process of implementing a sexual reproductive health program in. However, in practice, this ended up being a lot harder to achieve. And so the sample study ended up being 23 girls and women between the ages of 14 and 40 years old. This was mostly due to competing demands of AMOS staff and the girls we intended to interview. While it wasn't ideal, it did provide some valuable information for further program development. So going on to factors associated with adolescent pregnancy, the factors and consequences of unintended adolescent pregnancy can be life-altering for adolescents and their children and have been studied and evaluated across different settings worldwide. At this phase, we use routine data collection done by AMOS, the SRH sample study, and NDESA, and more broadly, international data to inform program planning. The team developed a problem tree and made sure to include factors that were contextually and culturally relevant. Main factors included poverty, less education, lack of data, rural setting, lack of SRH care and information, and early sex and marriage. For example, adolescents who are poorer, less educated, and living in rural areas are disproportionately more likely to become pregnant. This was true in the community served by AMOS, as we observed in our small sample study. Of the individuals interviewed, roughly 83% reported having children before age 20, 57% also reported not having completed primary school, and 80% were housewives. With regards to SRH care and information, in 2006, Nicaragua's government decided to ban abortions entirely in the country. And since abortion is illegal, the country itself has published little data on the enforcement of the abortion ban, as well as on health effects, including maternal mortality. Any data international organizations publish on abortions should be considered carefully, given that no abortion-related data were published on it in NDESA. So how can we improve data access? Well, in the private sector, organizations like AMOS could collect their own data, more specifically focus on adolescent pregnancy prevention, including knowledge of and access to effective contraceptive methods. Partnerships with universities and researchers would help to ensure robust research design and unbiased analyses. NGOs can also work with researchers to explore opportunities for being included in related topic studies that would be mutually beneficial to both organizations. However, it is important to acknowledge that NGOs in Nicaragua are at risk of closure if the government deems them a threat. Since the 2018 protests, the Nicaraguan government has ordered the closure of roughly 1,800 NGOs in the country. And while a majority of the NGOs that were ordered to close were political in nature, environmental, health, educational, and development organizations were also closed. In the public sector, ideally, the Nicaraguan government would conduct a census and a large health survey within the next 2 years, rather than relying on estimates based on 2005 numbers. Accurate population information is crucial to public health in general, but also valuable for helping to assess the extent of adolescent births nationally. Without these data, governments and public health professionals are required to make estimates that could be inaccurate, which ultimately affects allocation of resources and funding. Another INDESA survey would provide social and developmental related data and about births, family planning, sexual health, education, and more that can provide context to the numbers. Finally, global pressure may also be needed. Ultimately, the Nicaraguan government is responsible for the health and well-being of its people, and by extension, the collection and dissemination of public health data. In this scenario, the World Health Organization, United Nations, or World Bank would require all countries, specifically Nicaragua, to conduct a national census every 10 years, as is written in their national policies. These data would then also be required to be publicly available.
Recording.
And while national data may be insufficient, unsubstantiated, or lacking entirely, the Nicaraguan government, local NGOs, communities, and public health professionals can look to international best practices that have been proven to prevent unintended pregnancy and enable individuals to achieve their fertility goals. These practices include, but are not limited to, expanding community health worker programs, increasing educational attainment for girls, and improving knowledge, beliefs, attitudes, and self-efficacy around family planning. While there is currently a community health worker program established in Nicaragua and also one with AMOS, these programs can be improved by providing long-acting reversible contraceptive method training and resources to increase method choice for adolescents, as well as updated culturally relevant education materials. With regards to education, although schooling is provided by the government up until the secondary level, public schools are often underfunded, particularly in rural settings. Working is oftentimes seen as a more economically viable option than attending school, especially during harvesting season, particularly coffee harvesting season. At a more local level, organizations could consider applying for grants that help them provide economic incentives to help keep girls enrolled in school. Data have shown that providing economic incentives like conditional cash transfers can increase girls' retention as well as progression in school. Organizations could also consider ways to improve providing adolescents with the skills, resources, and belief in themselves about being able to correctly use the knowledge and resources they are given. Programs should focus not only on teaching adolescents about family planning methods, but also addressing the benefits and side effects of contraception so that they can make informed decisions that are right for them. And with regards to philanthropic support, grant awarding organizations should incorporate a focus on data collection to ensure that the programs they support have the intended outcomes and impact. Funds should be earmarked for analysts, data collection training, and standardization and dissemination of results. A final recommendation is to resume USAID family planning funding, which Nicaragua graduated from in 2012. In 2003, Nicaragua was identified as a country on track for graduation after meeting the total fertility rate and total modern contraceptive prevalence rate objectives. So while Nicaragua's modern contraceptive prevalence rate and total fertility rate have slightly increased from graduation numbers, the considerably high rates of unintended pregnancy and adolescent births that persist in the country since graduation should merit consideration of readmitting the country into the program. And finally, some thanks. So a huge thank you to Beth for being an amazing reader and mentor. This essay and presentation would not have been possible without her. To Dr. Sally Safi for being a wonderful advisor, and to my parents for all the support to get to this point, my sister for being a really good support as well, and my nephew Hunter for smiles, to my partner who has read multiple versions of my essay and presentation, and finally my lots of my friends and family from back home who are super supportive. And finally, I cannot thank Amos and Health and Hope team enough for allowing me to work alongside them. My time with them has been invaluable to my learning as a public health professional, and I deeply cherish all of my experiences with them. Thank you.
Excellent job, Natalie. Great work. So we have time for a few questions. All right, Shira dropped one in the chat. She asked, does or how does Amos plan on using the data that they collect? Would they want to, whoops, I lost it. Would they want to make a case for improved data collection to the government?
Yeah, that is a great question. So I guess I really can't speak too much for them, but I know that like during conversations while I was there with them, we did like discuss potentially, you know, their interest in like wanting to publish, but it was kind of with the idea of like, you just have to be careful with what you say. Just because like I had mentioned, like a lot of NGOs unfortunately like are being closed, and not even that, but it was just like, there's also like the citizenship aspect. I don't know if people have kept up with that. People are losing citizenship there as well. So, I mean, aside from the factors of like cost and like human resources, which is kind of one of the issues that unfortunately like small NGOs do have, But I think overall it was just, unfortunately, like, I mean, as you've kind of seen with the COVID-19 like pandemic, like public health tends to be politicized. And so I think you just kind of have to be, in this case, like they have to be careful with what they publish or say, at the risk of potentially being closed.
Great presentation, Natalie. I guess bouncing off of like how you said a lot of organizations have been like shut down and closed. Are there other organizations that focus on adolescent programming that maybe Amos like collaborated with, or if you can speak on that a little bit?
Yeah, that's a really good question. So as part of my like time while I was with them, I did like do some research into organizations that like existed to potentially create partnerships. I guess considering that there is like the constraint of cost and, again, human resources, like how can we expand and work together? So there is a couple of places. I didn't mention it too much in this, but Nicaragua currently has like a program called the Community Distribution of Contraceptive Methods, or ECMAC. And so they also provide methods, and they are in rural settings, but a lot of the issues like are involved with like stockouts and things like that. So that is a difficult barrier. I know UNFPA was also doing some work there. So even though USAID doesn't currently do stuff, like other organizations also kind of do some work there. There is also another organization called like Pro Familia that used to work with USAID prior to them leaving, that also did contraceptive, like sexual reproductive health work. And so those are like the main ones. I was able to find one like recently that like launched in 2000, like last year, called Shava, which is a comprehensive app, which I thought was really interesting, that was like developed. And so I guess we'll have to see if that's like a helpful thing in like more technology based. Yeah.
Awesome, thank you.
Maybe I'll ask of the suggestions that you made. I think that there are some that are within the control of the community organization, and some that are much bigger in scale, like reinstating USAID funding, or getting funding for a national large-scale survey. What do you think is like realistic in terms of your suggestions? Do you think that some of those things like might happen?
I mean, ideally, in an ideal world, they would. But like, given that that wasn't the case, like that's kind of what like the best practices was about. So like in the case that we can't actually get that done anytime soon, the best thing that we could do is just like turn to other organizations, or to like practices that have been done by other organizations, and seeing like what they did and like how that works and how we can potentially implement that, taking the cultural context and applying it to ours. So yeah.
Great, thanks. All right, well, great job again. And we are to our last presentation. And we have next up is Shira Tikofsky. I'm sorry if I'm saying that incorrectly. Shira comes to us from UC Davis, where she majored in international relations, and she'll be talking about quality of contraceptive counseling today.
Hi, so can you guys see my screen and everything?
Yep, looks great.
Okay, great. So my name is Shira, and I will be presenting on the quality of contraceptive counseling and person-centered care using a cross-sectional study among a sample of women in Ethiopia. And to preface, I'm going to be referring to those born of the female sex as women with she, her pronouns, but I want to recognize that there are individuals across a range of gender identities that require consideration in family planning. So what is high quality and person-centered family planning care? So in general health care, when treating conditions like diabetes, providers often put a strong emphasis on using the most effective interventions based on clinical evidence to support the best possible health outcomes for their patients. But according to the World Health Organization, high quality healthcare is defined as that which is not only clinically effective, but also safe, timely, integrated, equitable, and person-centered. Person-centered care means that services are tailored to each person's needs and preferences. Family planning is unique, as only the individual can decide her desire to become pregnant, raise a child, use a contraceptive method, or no method at all, or how much risk of a pregnancy she feels is acceptable when choosing a contraceptive. Therefore, providers must prioritize women's individual preferences alongside evidence-driven interventions. This person-centered and human rights framework is essential to family planning because ultimately a woman's ability to make unrestricted and informed choices about her reproductive well-being is a fundamental and basic human right. But significant barriers exist to accessing high quality and person-centered family planning, which increases the risk of negative health outcomes. These risks are even greater among populations already disadvantaged by their social determinants of health, including factors like their age, income level, etc. So ultimately, the failure to use a human rights and person-centered approach can hinder the quality of care and prevent a woman's ability to achieve her reproductive goals. So my study focused on family planning in Ethiopia, where access to family planning increased significantly over the past few decades, but currently 36% of women experience unwanted or poorly timed pregnancies. Only 41% of women who are reproductive age are using contraceptives. In addition, existing studies show that the percent of women who receive high quality contraceptive counseling is not only limited, but declined by more than half in recent years, from 39% in 2015 to 12% in 2019. And they've also pointed to notable disparities in the quality of family planning. So this directs us to the gaps in research. First, it's unknown to what extent quality counseling is differentially provided based on women's individual characteristics. Second, to my knowledge, there are also no known estimates of the extent to which the quality of contraceptive counseling is aligned with women's needs and preferences for family planning at the national level. And these gaps are significant because there's a need to understand how receiving higher quality care is not only related to reproductive autonomy, but to women's contraceptive experiences, like choosing to use a provider-dependent method, or if they're using their preferred contraceptive method. So part of these gaps in knowledge are due to reliance on traditional measures of quality in contraceptive care, which focus on whether an individual receives basic information about their contraceptive options during counseling. However, a recently validated measure, the QCC-10 scale, or the Quality of Contraceptive Counseling Short Scale, offers a new measurement approach to investigating quality in contraceptive care. It applies this human rights framework to assess if women have negative counseling experiences and the extent to which contraceptive services are aligned with their needs or preferences. To do so, the scale asks women to rate their level of agreement with 10 statements based on their most recent family planning experience. The first category of person-centered care is interpersonal relations, or if the provider established a destigmatized environment of trust, dignity, empathy, and mutual respect, and that's measured by 3 statements. The second category is information exchange, which includes 5 items that assess if a woman received adequate and easily understood information to select the contraceptive method best suited to her needs. Finally, the 2 items in the disrespect and abuse domain are characterized by poor counseling experiences, such as provider coercion to use a certain method type. So first, the study aims to estimate the distribution of quality family planning counseling using the QCC-10 among contraceptive users. Second, we assess how the degree of quality family planning counseling differs by women's sociodemographic characteristics. And third, we examine the associations between quality counseling and use of provider-dependent methods, which include contraceptives like IUDs, implants, injectables, and sterilization, and the use of preferred family planning methods. To do so, I used PMA Ethiopia's 2021 cross-sectional survey of women aged 15 to 19, and PMA Ethiopia uses a multi-stage sampling design described on the slide to collect data across all major regions in the country. Our analytic sample was restricted to 2,941 women who were current or recent contraceptive users and sexually active. The study's primary outcome was measures of quality in contraceptive counseling that include individual QCC-10 items, where each item had a response options ranging from completely agree to completely disagree. Then we used the QCC-10 composite score, which was calculated as an individual's average response to all of these items. And finally, the distribution of women's QCC-10 composite scores were divided into the lowest, middle, and highest tertiles of quality counseling. Women's sociodemographic and contraceptive characteristics were measured categorically by age, partnership, education, wealth quintiles, residence, parity, region, and method. Secondary outcomes included women's method type currently or recently used, which was categorized as provider independent or independent. And provider independent includes contraceptives like pills, emergency contraceptives, condoms, etc. The descriptive analysis first explored key variables, including the QCC-10, sociodemographic characteristics, and outcomes. Next, unadjusted and adjusted linear and logistic regression were used to explore relationships. And adjustment variables include sociodemographic characteristics that are mentioned on this slide. And the complex survey design was accounted for in all of the stages. The results show that women in Ethiopia are receiving significantly different levels of quality and contraceptive counseling as depicted in this histogram. And on average, users receive moderate levels of quality care, specifically 2.69 on a scale of 1 to 4, and Cronbach's alpha of 0.85 indicates high internal reliability consistency. These differences are explored in more detail by women's responses to each QCC-10 item. So when looking at women's level of agreement with the first quality domain of interpersonal relations, we can see relatively equal proportions of women that agree and disagree with having experienced a positive relationship with their provider. In the next quality domain, women report higher levels of agreement with having received adequate and tailored family planning information, but they also report higher levels of complete disagreement and complete agreement, which just further emphasizes the significant variation in the quality of care being delivered. Finally, the disrespect and abuse domain has a high level of disagreement on items, meaning that women received better care. Social disparities in QCC-10 scores reveal inequities in quality of care. Women who are uneducated, not in a union, have 1 to 3 children, are located in the Amhara region, reside in rural areas, poorer, or who were adolescents aged 15 to 19, received significantly lower quality of person-centered counseling. Now transitioning to the contraceptive outcomes of the study, overall, we see that a high proportion of women use contraceptives that rely on a healthcare provider, as depicted in the red bars, despite the differences in the quality of care that they received. And the different quality tertiles are listed along the x-axis. However, in our adjusted models, we find that women who received the highest quality care had more than double the odds of using provider-dependent methods than using provider-independent methods when compared to women who received the lowest quality care. When only focusing on women who are using contraceptives, we found that across all levels of quality, a high proportion of women are using their preferred family planning method as depicted in the dark blue bars. But in our adjusted model, we found that women who received the highest quality contraceptive counseling had 68% higher odds of using their preferred methods compared to those who received the lowest quality care. So in summary, these results had 4 key findings. First, on average, women using contraceptives are only receiving moderate levels of quality in family planning counseling in Ethiopia. Second, there are significant inequities in person-centered family planning based on women's sociodemographic profiles. Third, findings show that women who receive the highest quality contraceptive counseling are more likely to use their methods that are provider dependent. In addition, because the QCC-10 scale accounts for experiences of provider coercion, these results demonstrate that women receiving person-centered care are more likely to voluntarily choose contraceptives that require provider involvement. Lastly, current contraceptive users who receive the highest quality family planning counseling are more likely to use their preferred contraceptive method. So what are the implications of these findings? The evidence sociodemographic inequities emphasize the urgent need for strategies to improve equitable person-centered family planning counseling and women's agency to exercise reproductive autonomy. Therefore, efforts to improve access to quality care must address disparities, low-quality counseling, and improve existing person-centered strategies, ultimately fostering trust between providers and patients, recognizing bias, and providing individualized information about a wide range of contraceptives can lead to higher autonomy and improved health. But additional research is needed to understand the challenges in providing equitable counseling and explore the potential of a quality threshold, which was evident in our adjusted models. Lastly, programs should improve the extent to which family planning care aligns with individuals' unique needs and preferences in order to support women in achieving their reproductive goals and fundamental rights. Thank you. I want to acknowledge my advisor, Celia, my PMA faculty, teachers, friends, and family who were able to join the Zoom today and offer your support over the last couple of years. Yeah.
Great, thank you so much. Excellent work, super impressive. We have time for a few questions. Why do you think that the traditional measures of quality largely don't incorporate a person-centered framework?
That's a good question. I have a lot of thoughts to that, but first I'll mention that providers usually prioritize the effectiveness of interventions driven by clinical evidence, which has kind of created a paradigm in terms of what should be prioritized as a standard of quality and care. But recently, there's been a greater recognition that person-centered care and greater attention to patients' preferences and values are critical in ensuring quality in family planning services, which is essential to women's right to make decisions about their own bodies. But at the end of the day, measuring the receipt of person-centered care as a domain of quality is challenging. And person-centered care isn't standardized and really just depends on each person's preferences and expectations compared to other aspects of quality. So efforts to determine someone's care experience rely on subjective reports. So they don't really account for negative experiences of care. And that's why I was interested in exploring the QCC-10 short scale, which was also only recently validated.
There's another question that you mentioned, a study implication that there's a threshold in quality family planning care. Could you talk a little bit more about that?
Yeah, of course. So among my secondary contraceptive outcomes that included women's method type used and use of her preferred contraceptive methods, I noticed that the adjusted results were only significant among women who received the highest quality of care compared to the lowest, meaning receiving low or mid levels of quality counseling had no significant impact on contraceptive methods used. So this suggests that there's potentially a threshold or a level of quality and person-centered care that providers must reach in order to have an impact on women's ability to exercise reproductive autonomy and use contraceptives aligned with their unique needs and preferences. I thought it was really interesting and would be curious to learn what defines this threshold and how it can be achieved in family planning to support women in achieving their reproductive goals.
And there's one more question that you mentioned the demographic differences, but are there differences in terms of socio-demographic differences for the specific domains of quality of care?
Yeah, that's a really great point. I actually had a similar thought. While I wasn't able to investigate differences individually in quality statements by women's backgrounds, I was able to explore disparities in the information exchange domain because this category had 5 statements, which allowed for it to be statistically valid and kind of creating an average score of women's responses. But I wasn't able to address that in the presentation due to limited time. So overall, the results of that were largely comparable to the socio-demographic disparities based on women's overall care that they received. There were some differences. So specifically when looking at quality of care received by women's different wealth levels, we only saw significant differences in the quality of information between women from the middle and lowest wealth quintiles. But results also had similar implications that women from disadvantaged backgrounds are disproportionately receiving inadequate contraceptive information that doesn't meet their needs in family planning care.
Great. Well, thank you so much again. I think we're right at time. Again, I want to thank our presenters who had just really excellent presentations today. Thank you for staying on time. That is much appreciated as well. And again, thanks to all of the readers and family and friends and colleagues who are here supporting students. We really appreciate you being here. And come back next week, same time. There will be, again, 3 different presentations or sections of presentations of our final round of master's essays. So great job, everybody. Thanks again for joining.